Welcome to Conversations in Lung Cancer Research, a TOGA podcast where we discuss the latest breakthroughs in lung cancer research and treatment for Australia and New Zealand. My name's Associate Professor Gavin Wright. I'm a thoracic surgeon and the Director of Surgical Oncology at St Vincent's Hospital. I also work at Peter Mac as both a thoracic surgeon and also at the Victorian Comprehensive Cancer Centre as the Research and Education Lead for Lung Cancer. I'm the surgical representative on TOGA's scientific committee. The Thoracic Oncology Group of Australasia acknowledges the traditional custodians of the land on which we live and work. We pay our respects to their elders, past, present and emerging. We also extend that respect to all Indigenous people. In today's episode, we'll explore the impact of smoking-related stigma, its role on the National Lung Cancer Screening Program participation in Australia, and the best practices in delivery of care to patients with a smoking history. Today on the show, we're excited to have an amazing panel, which is essential obviously for this topic. We have Dr. Allison Black, an oncology consultant at the Royal Hobart Hospital. She sub-specialises in gynecological and lung cancers. Henry Marshall was a thoracic physician at the Prince Charles Hospital and the University of Queensland Thoracic Research Centre. And Suzanne Chambers is a health psychologist working as a practitioner and researcher in psycho-oncology and the Executive Dean of Health Sciences at the Australian Catholic University. I'd like to welcome them all to TOGA's Conversation in Lung Cancer Research podcast. So our topic today is stigma related to people smoking. And I thought I'd start with Suzanne just to help us understand what stigma is and how it affects patients in this context.
Thank you, Gavin. I guess the first thing to understand is that stigma is a social context, a social construct, if you like. So it arises when in society an individual is labelled as tainted or less worthy as a result of a characteristic that they have. And so you see stigma across a range of characteristics, but in the case of lung cancer, stigma is arising from the idea that if you've got lung cancer, you gave it to yourself from smoking. Also the idea that lung cancer is associated with a horrible death. And I think we've all seen this in our practice over the years. One of the reasons why that's become amplified is because as a necessary way to reduce smoking prevalence, to aim to reduce lung cancer incidence, we've used advertisements that really try to hold up smoking as a bad behaviour, a morally bad behaviour. And of course, that's been an important thing in reducing smoking prevalence, but it's had this side effect that we haven't really done anything about, to be frank. In addition, when you think about tobacco legislation, which is important also to make workplaces safe and to reduce people's exposure to passive smoking, what that creates is this idea of smoking as a very bad personal characteristic. And we've all seen this over the years. The flow-on effect of that then is that as well as stigmatising smoking, it stigmatises lung cancer. And I think it's interesting to note that despite all the work that's gone on to try and reverse that effect and take this blaming away from lung cancer patients, it still persists. And you see it in people who don't smoke as well as people who do smoke. It has quite serious psychological side effects. When stigma is internalised as shame or guilt, that is a contributor to depression in lung cancer patients. It just makes the psychological experience of this so much worse for the patient as well as for the patient's family. With little real action, I feel, to try and overcome that. So it's a really important issue, and lung cancer patients have, up to 50% levels of elevated clinical psychological distress, double most other cancers. So this is a really serious problem for our patients and our patients' families.
Absolutely. And it's like the blame has been switched from companies that have created a deliberately addictive product to make money onto the poor patient that got addicted. That's what do you think, Henry? Is that a reasonable thing to say?
Definitely. This has been a tool that's been developed and harnessed by the tobacco industry in a way to shift blame and shift focus from them onto individuals who smoke. And they've been cultivating, freedom of choice has been their mantra since the sort of 50s and 60s. It's worked very well in defending tobacco industry from litigation, but it's become part of their policy, really. So it kind of protects the industry from scrutiny because we know that they target children and young people. We've seen that with vaping, right, for example, absolutely designed to hook kids. And yet the industry will say, oh, this is a freedom of choice. And whenever tobacco control legislation comes up, the industry and their spokespeople and the people who kind of do their work for them will say, oh, this is a freedom of choice, nanny state and all the rest of it. So the industry is absolutely part of this problem. But as Suzanne says, the person that ends up suffering from this is the patient at the end of the day.
Look, this has really become a very important issue, even more so now that we have National Lung Cancer Screening Program, which I'll get Henry to talk a bit about the evidence of shortly. We need to be able to get as many people who've smoked the quantity to put them into the high risk group along to get screened to reduce the risk of mortality or death from lung cancer, because we want to find that cancer early. And if there is stigma, our concern is that people won't turn up to get their potentially life-saving scan. So I might just throw you for a sec, Henry, just to talk about lung cancer screening and how important that is for people who smoke.
Yeah. Lung cancer screening is one of the tools in our toolbox, I guess, really, in our battle against lung cancer. We're thinking about prevention, which is tobacco control and smoking cessation. We're thinking about early diagnosis. Think of all the amazing technology that we've got at our disposal nowadays, and then all the treatments that we've got and the advances, Gavin, in surgery and, medical oncology treatments have all been incredibly important. And what we've been missing for years in Australia is a screening program. And of course, that started out almost a year ago. So it's coming up for its 1 year anniversary in July this year. And a fantastic program brought to Australia really by, the government and Cancer Australia and NACCHO have all worked together to make it happen, with the aim to detect lung cancer early in people between the age of 50 and 70 who have smoked for at least 30 pack years, and a pack year being 20 cigarettes a day for a year. That would be 1 pack year. So 30 years of 20 cigarettes a day, either currently smoking or previously smoking but quit no more than 10 years ago. So that's the sort of eligibility criteria. It's based on very good high-level international evidence that shows that lung cancer screening can reduce lung cancer mortality by around 21 to 24%.
And I think the lung cancer screening program is also an extra, touch point that doctors and health practitioners could use to help people to give up smoking. But I think it's important for people to understand that it is not a requirement to have stopped smoking in order to get screened. I think that's very important. And just as a follow-on from that, people may feel, oh, I'm smoking, therefore I don't deserve the treatments, or, and I might just ask Allison here, is that an attitude you've seen in the past with patients who smoked, feel that perhaps they're not worthy of treatment, or they may be more reluctant because of that?
Yeah, absolutely, Gavin. I always make it quite clear to patients when I first meet them that no one deserves cancer, regardless of what activity you've done in the past. And we don't assign that kind of blame to other diseases, so we shouldn't be assigning it to cancer. But particularly, I work in Tasmania. We have some higher smoking rates in certain pockets of Tasmania, and people do come in saying, well, I deserve this cancer. I'm not too sure if I want treatment. And certainly there is no clear data that smoking makes you less likely to respond to treatments. The standard of care around Australia really should be a good pathological diagnosis, molecular profiling, and a discussion at an expert multidisciplinary team meeting, and that's regardless of whether you've smoked in the past or not. So I think we just as clinicians, we need to make that really clear right from the start of meeting people that there is no blame assigned to whether you've smoked in the past or not, and that we just need to make a plan together moving forward that's going to be in the best interests and is evidence-based for our patients.
And we have new therapies, particularly immunotherapy, and a lot of patients who have smoked may well be eligible for immunotherapy. And there's no evidence that there's extra side effects or less response with immunotherapy, for example, is there, Alison?
No, and we often know that, some people who have smoked in the past, their tumours will actually have quite high levels of indicators to us that they'll respond to immunotherapy and can actually respond extremely well to immunotherapy. I mean, really, someone's smoking history is a little bit irrelevant in regards to looking at the use of immunotherapy. We largely look at the whole person, their other comorbidities, and whether they're fit enough to have treatment. And we're using these immunotherapies before surgery, and people respond and certainly, do as well regardless of whether they've smoked or not. There can be the risk of complications in regards to radiation and surgical outcomes, but I think all the professionals involved with lung cancer treatment are really used to assessing people prior to those treatments and, getting people through their treatment safely.
And certainly I can say from a surgical perspective, about 50% of patients operated on are still smoking, and about a third smoked in the past at some stage. Certainly the risk of complications such as pneumonia or not coughing up your muck out of your lungs properly, that sort of thing, are higher. But we've been operating on patients who've smoked for decades, and our techniques have got better. We've got less invasion. We get people who are quite heavy, with heavy smoking histories through their surgery. And I have heard secondhand of surgeons not wanting to operate on people who are currently smoking. I think my personal view is that's completely unacceptable. And that's, I think, Suzanne, that I'm sure would compound anyone's sense of shame or guilt or add to their stigma. Would you agree?
Absolutely, I would agree. I mean, I think it's a really serious problem that we really haven't come to grips with. I remember years ago, goodness, it's probably 10 years ago, but I don't think things have changed that much. I wrote a grant to do a trial of psychological intervention for people with cancer after having done a pilot where we got moderate to large improvements in depression in these patients. And so it was a fantastic result, great little pilot. And the sort of feedback I got from reviewers, one even said something like, surely people should take responsibility for their own health. And so there were a number of those. It was appalling, frankly. I just want to say we've got this widespread problem that exists in the minds of some health professionals as well as the community. And if we really want to change this, we're going to have to do something big. I think we need to address this from the patient point of view. What are we doing? What psychological care are we providing to newly diagnosed patients and their families right now at that level to relieve that suffering? And then we've got to say, so what are we doing about health professionals? And of course, this podcast is something that is directly addressing that. But then we've got to say socially, what are we going to do in society to change social attitudes? And it's got to be a three-tiered approach if we really want to shift this. And, so are we just going to let it go on, or are we going to get the government to help us do that? If they're happy to, which is wonderful, to support a screening trial, what are they going to support to help us address these barriers to that screening trial, which I think you've done an excellent job of explaining. What does that mean when we know smoking is seen as an undesirable characteristic in society, yet that is the variable that we want to look at for entry into a trial? This is very tricky, but also an excellent opportunity to do something really interesting and clinically important in how we deal with stigma in health, because this is not the only cancer, of course, that has stigma. We get it in head and neck cancer as well, and a range of other ones. It's just really more pronounced in lung cancer because of the smoking connection and the size of the problem.
Henry, this problem really extends throughout the entire patient journey. You'd have to say it right from the diagnostic through. What are your thoughts on that?
Yeah, look, I think I absolutely agree with what Suzanne said. This is, this affects every level of society. And if we think about the impact of lung cancer and the research funding that it receives, so, it accounts for 20% of cancer deaths, and it gets a fraction of that in terms of, cancer funding. That comes down to, bias and stigma in reviewers and policymakers. So we see it at that end right through to, patients rocking up for treatment. I mean, I think turning up for lung cancer screening is quite a big deal for people. It's quite a scary option. And if any of our listeners have been for screening themselves with colonoscopy or whatever, there's definitely anxiety that happens before that. What's it going to be? What's it going to end up like? And I think, that stigma makes that even harder for people to even just turn up to have the conversation with their GP. So this is not a theoretical thing that we're talking about. It's got, huge practical implications and for patients. Can I just add on to a point, that Allison made, about the treatment? Well, there's good meta-analysis now showing that if you can quit smoking at or around the time of lung cancer diagnosis, you can increase your overall survival by 30%. So that, 30% overall survival improvement, would be very welcome for any drug trial, right? If you were sponsoring a new drug and you got a 30% increase, you'd be very, very happy. And helping someone quit smoking can get that level of improvement. And it's such a simple and cost-effective treatment to provide. We just don't do it well enough in the healthcare sector. And I think that's to our shame, basically. We should be doing this. There was a nice paper in the UK talking about the delivery of smoking cessation. And it said basically, in very bold terms, if you don't deliver something this effective to your patients, you're negligent. And you're negligent at an individual level, you're negligent at a systems level, in just the same way that if you didn't look for and treat cancer, you'd be negligent, right? So I don't think I've seen any patient sort of litigate health professionals or health systems for this, but it could happen, and we need to do a much better job.
And Henry, just to add to that, I think you're absolutely right with the improved survival if you can stop smoking, but you're also going to live better. Your quality of life will also be better. So you're right, we have a responsibility to discuss this with patients when we meet them as well.
And Allison, the other issue for me is issue equity. And being in Tasmania, it's probably particularly an issue for you because groups such as Indigenous, low socioeconomic, rural, regional, etc., will have higher rates of smoking. So we're actually worsening the equity issue, inequity of treatment by any form of stigmatization or bias related to smoking.
You're right. And often, these patients, we know patients in rural and remote areas actually, do worse often with their cancer treatment the further you live from a major centre. And so these patients are already often have that disadvantage, and then we add to it as well with the stigma. So it is a real problem for these patients. We see it really regularly. I do a little education program in schools each year, often in poorer socioeconomic areas. And it's really interesting, some of the attitudes that come up. When I raised recently about how could we keep our lungs healthy, the number one thing that came up even before smoking was about sugar. So somehow, as some of these communities are getting messages about sugar being bad, we're not getting the message about the main thing that we need to look at, smoking in these environments. And that's where the bigger impact would be.
Yeah. So the other issue I was talking about really, or I wanted to cover is reluctance to have things like curative radiotherapy in patients. Maybe Suzanne, if you could sort of go through what's in a patient's mind where they actually feel reluctant to have a treatment.
Well, in my experience, it's a fear of the side effects of treatment would be the main one, uncertainty about what the benefits might be. I mean, there are those sort of objective facts that a patient will try and weigh up in making a decision about treatment. And the ideal decision needs to be what we call a shared decision, which is where the patient is able to make a decision based on their values and their priorities, weighing up the pros and cons and with adequate support. There are models for this that have been developed, decades ago that are very, that are proven and that are effective. But I suspect that we don't really have many people in our systems that are trained up to do supported shared decision-making with patients. I think The other thing is just generally, if you've got high levels of psychological distress and high levels of anxiety, your cognitive function just doesn't work as well. And so it's more, if in a way, if you think about your brain as your office desk or your workspace, when you're highly anxious, it's harder to find things and move things around. This is where I think, a holistic psychological care becomes really important. I often get patients referred to me who are, in a state of decisional uncertainty and just can't decide what they want to do with a particular treatment type. And what I'll be doing is supporting them in a shared decision-making model, but at the same time identifying what's the main causes of their anxiety at this point and giving them some skills and strategies to try and reduce that so that they can make effective decisions. That's from a psychological point of view, but of course there's always practical obstructions to treatments as well. Can they get there? Can they afford it? Have they got family support? All of those things, which is where it just becomes really important to take a holistic view of what's going on for our patients, and really understanding that. And that takes time and someone who can sit with them, which is where, there's a range of models that I think are really good at this, like lung cancer specialist nurses. That I know the Lung Foundation of Australia has those available. Having a health psychologist that you can refer your high-risk patients to, knowing what the community supports are, and making sure that every treatment centre has a pretty clear plan for what's our care framework for our patients, and really looking at people holistically so that they know they've got a team that's around them that's going to help them get through this and have some confidence that they're not just going to struggle on their own.
And Henry, obviously getting people to give up smoking is absolutely vital. How do you think we can do that without worsening that stigma? Are there sort of methods we can use?
Yes, and I think that they are methods that every health professional knows about, all right? We're not going to talk about anything kind of like new or magical here. It's about putting your patient at the front and centre of the treatment and working as a team in a respectful and non-judgmental way. We do it for everything, right? Except smoking. We just don't do it so well. But, I think that, respect and compassion and kindness are really important. Most people that I talk, we all see an older population, right? If we're dealing with people with lung cancer, we're dealing with an older population of people. They picked up smoking when they were 11 or 12. They nicked their older brother or sister's cigarettes, or they stole one off their dad or whatever. And this was at a time when a lot of people smoked, and it was seen as a very normal kind of thing to do. It was not frowned upon at all. So that's how they sort of started and began the journey. And of course, there were adverts on TV and radio and sporting events. So a lot of exposure to say, hey, smoking is really cool. It's really normal. You ought to be doing it. And if you're not doing it, you're mad. Well, we've totally flipped that around now. And so, but we need to recognize that kind of history. I think the other thing that we need to understand is that a lot of, addiction is a complex thing, all right? You've got sort of biological processes in the brain. You've got a lot of psychological things happening, triggers, and behaviors going on as well. So it's a real mixture. But a lot of what we see in smoking is genetically determined, and it's how you metabolize your nicotine and your medication. So, some people will tell you, I tried to smoke once, I didn't like it, and I never took it up. Right? Why is that? Other people will say, I had a cigarette and I was literally hooked from the first few puffs. So, why should that be? Well, about, up to, 50 to 3/4 of that variation is genetically predisposed. Maintaining your smoking addiction is genetically predisposed in the majority of people. Quitting success, 50% of that can be explained by genetic variation. And then, the withdrawal symptoms, which are important in sort of stopping people from quitting, right? To avoid the withdrawals, 30 to 50% of that is genetically determined, right? In the dopaminergic system, opioid receptors, the way that your cytochrome P450 system metabolizes drugs as well. This is outside of your control. It's not that people are stupid, lazy, or don't understand the risks. This is a very tough thing. So I think as medical professionals, let's understand that first of all, and then, and then give people the best evidence-based help that we possibly can.
Well, I might take just some final comments. Alison, do you have any further things to add?
No, I think really, Gavin, it's what we've said is that it's giving everyone across the country equitable care, and that really their smoking history should not impact on decisions moving forward about their care. They should still be, open to treatments regardless of whether they're smoking or not. We just need to make sure everyone is being discussed in a MDT as the gold standard, and that we're looking at all options for each individual patient.
And Suzanne, do you have any closing comments you wanted to get out?
My closing comment would just be about something we haven't really discussed, but I think it's, what we're trying to move towards is a survivorship care framework for patients that's holistic. And I think that would be the gold standard of where we need to land, so that when patients are diagnosed with lung cancer, we immediately put that system into play with that particular framework.
Henry, do you have any last comments?
Yeah, well, I do actually. And it's really something practical as well that we can do. And it's all about language. And so, I'm sure you'll have seen the IASLC has got a language guide. It's really important that we put this into practice. And this is really separating out the individual from the behaviour, and we must stop using labelling language. We can't talk about smokers in the same way that we can't talk about diabetics or asthmatics or whatever. We must put it into person-centric language. So people who smoke or people who used to smoke. That's so important. It's important in our day-to-day conversations with our patients and our colleagues. It's important also in how, in our publications, right, as well. We need to talk about people who do something or don't do something rather than labelling them with a behaviour.
Well, thank you very much to Allison, Henry and Suzanne. It's been a great exploration of stigma related to smoking and lung cancer. And I think it's very clear what an important issue this is. It's something we really have to face head on. Thank you.
Thanks, Gavin.
That brings us to the end of this episode. Thanks, Suzanne, Henry and Allison for joining us during that discussion. As always, thanks for listening to TOGA's Conversations in Lung Cancer Research. If you enjoy our show, please rate and review us on Apple Podcasts or Spotify.